Good morning, all. So now here we are back with our class on benign bone tumors, and today being class the second class on this issue. There are so many benign tumors, and many of them are so important that we can't skip any one of those. So we have to be attentive in all of them. In the last class, we had seen some of the benign tumors like enchondroma, osteochondroma, osteoid osteoma, and osteoblastoma. Today, we will start with chondromyxoid fibroma, which is also called as CMF. It is least common benign cartilaginous bone tumor. The incidence is 0.4%. Age may vary from 10 to 30 years. Equally spread in male and female. The site may be upper end of tibia, lower end of femur, lower end of fibula. Pathology is concerned, you find collagen fibers abundantly in this tumor, whereas in chondrosarcoma, we don't find so much of collagen fibers. So that's a big difference. Cellular population predominantly chondroid in the chondrosarcoma, whereas both chondroid and myxoid in this case. So this is basically how do you differentiate between CMF and chondrosarcoma. CMF, you get more of collagen fibers. In CMF, you find both chondroid and myxoid, while in case of chondrosarcoma, you find more of cartilage, less of collagen, less of myxoid. It has a very nodular architecture, and lobules of cartilage with myxoid features are widespread. Fibrous septae separating lobules can be seen. And in this septae, you can also find giant cells. This is a typical slide showing how the sheets, the fibers, collagen fibers are there. You can find cartilage cells are there. You can find in between myxoid areas are there. This is a classical case of CMF. This is on high zoom. Now, clinical features are concerned. Patient may present with mild pain, swelling. There is a mass attached to a bone. Sorry. Yeah. On X-ray, you can find a translucent mass of variable size located eccentrically in the metaphysis. Within the tumor, faint trabecular pattern can be present. It is usually present. So, a translucent mass of variable size, which is eccentric in and usually in the metaphysis, with trabecular pattern is classical of CMF. The treatment is very typical. You have to excise it and you have to do a bone grafting. You can find this is a case of, this is an X-ray of pelvis showing ilium bone and along with the sacrum. This X-ray so now we can see in this X-ray there is a lytic lesion on the ala of sacrum and adjoining part of the ilium. This is the classic case, what we were discussing. It is another case of chronic myxoid fibroma, and you can see there are fine trabecular pattern. It is in metaphyseal area and very classical. Now we go to chondroblastoma. Chondroblastoma is a benign tumor arising in epiphysis consisting of polychondroblasts, small foci, chondroid tissue, osteoblasts, giant cells, small foci of calcification. Its importance lies into differentiate from GCT. We have to be very careful when we see this case because we often confuse it with giant cell tumor. Its incidence is almost 1%. Males are again more affected, 1.8:1 ratio, and age is between 10 to 15 years. It's comprised of ovoid, round, and spindle cells. Nuclear clefts or grooves can be seen. Osteoclasts like giant cells can be present, hence it is confused with GCT. At some areas, you can also find hyaline cartilage. Calcification around individual cells is very common. This you can see, here you can see giant cells somewhere, although not here, they are forming, but mostly it is cartilage. Here you can see giant cells. These are giant cells. So don't confuse it with the GCT. Its usual site is upper end of humerus, lower end of femur, upper. X-rays show lesion is eccentric and involve less than half of the entire epiphysis. Border of the host bone sclerosis is present and small punctate calcification is present. Again, the treatment is same. We have to cure it out and do a bone grafting. Now we see some X-rays, upper end of humerus, lytic lesion, purely in epiphysis in this case, and you can see not all of the epiphysis is involved, and there is a white sclerosis line, which is classical, and the usual size is more than half centimeter. The same case you can find in the head of femur, sorry. It's an X-ray showing hip joint to the left side, and you can see a lytic lesion in the head of femur, which is osteoblastoma, chondroblastoma, sorry. The same case on X-ray, on MRI will be is clearly seen, where you can see a lytic lesion in the epiphyseal area of the head. The most important benign tumor in bones is a benign giant cell tumor. It is an osteolytic lesion arising from the epiphysis, common in young adults. Incidence is 5%. The usual age is between 20 to 40%, whereas 70% of cases are seen in this age group. And the usual site is epiphyseal region of long bones, pelvis, and sacrum. Pathology, it's a soft tissue tumor, very friable, readily bleeding tissue, contains cavitations and small cysts. The color of the tumor varies from reddish to chocolate brown, and the presence of abundant tumor giant cells is classical. Spindle cells indicate malignant potential exists. Clinical features, it undergoes a very chronic course. The swelling, the pain, the pathological fracture may be seen in such cases, and the eggshell crackling is very classical for a GCT. When you press it, it can crackle because the periosteum, the cortex is so weak, fiber, that it can crack on your pressure.
It is also known as a locally aggressive tumor because it expands like hell. There can be in between the uniformly distributed giant cells, you will find a background of a plump mononuclear cells, and you have to differentiate it with brown tumor, non-ossifying fibroma, fibrous histiocytoma, aneurysmal bone cyst, osteosarcoma with prominent giant cells. There can be osteosarcoma with prominent giant cells. So that has to be differentiated. This is a slide of a GCT where you can file groups of giant cells. You can find 1, 2, 3, 4, 5, 6. Oh my God. And in between is a background of mononuclear cells, classical giant cells, no doubt about it. X-ray may show cortex is expanded and thin, osteolytic lesion here basically no pedestal new formation can be seen. Remember, it is a benign tumor which has no pedestal reaction. Thin septal bone traverse the anterior and produce soap bubble appearance. Such cases, we'll just continue again. So now here's an X-ray of a giant cell tumor showing a knee joint, right side, and you can see there is an osteolytic lesion on the lateral condyle of femur. There is a narrow zone of transition showing it is a benign tumor, but you can see there is a break in the continuity of the cortex showing it is an aggressive tumor. So now once it is aggressive, it is on one side and shows features of benign. That means it is a benign aggressive, then means you have to think of a giant cell tumor, no doubt. How do you treat a giant cell tumor? There are many uh, treatments. Ultimately, what I want to show you. If it is an aggressive tumor, you have to really do en bloc excision. You have no choice. You have to really en bloc excise and you have to go for a better prosthesis or orthodesis. But if you have a normal, less aggressive benign tumor, in that case, you have many options. Those options include there are so many options to treat a giant cell tumor. The first was simply to do curettage. Then came curettage and bone grafting. Then came extended curettage. That means you have to curate it and you have to do, you have to use some adjuvants. Adjuvants can be phenol or liquid nitrogen. All these things reduce the rate of recurrence. But once you have got a big cyst, you have to really fill the cyst with bone graft or maybe cement. One new operation has come up for the giant cell tumor near a joint. It is sandwich technique, where once you do an extended curettage and we use phenol and we are sure that there is no tumor cell inside, what you do is just because the tumor is just beneath the articular cartilage, you lay down grafts, bone grafts under the articular cartilage. After bone graft, you lay down a layer of gel foam and you fill the rest of the cavity with bone cement. So the majority of the cavity is filled with bone cement. Now bone cement when forms, hardens up, it is an exothermic reaction and that exothermic reaction can damage the bone grafts which we have kept under the articular cartilage. Hence, we keep a layer of what we call gel foam between cement and the bone graft. It is called a sandwich technique. Using liquid nitrogen is also called as cryosurgery. If you use radiation to these cells, to this tumor, CCT, that can increase the chances of its conversion into malignancy. So, but when there is a weakness, you do en bloc excision, and ideally you should go for a mega prosthetic replacement of the joint, or you do arthrodesis. So this was what we call as giant cell tumor and its treatment. Now, another other is aneurysmal bone cyst. It is a benign lesion excentrally located in metaphysis. It is cyst in spongy, multiloculated, filled with blood. Incidence is quite less, but still not ignorable. It is 1%, sex equal male female. Usual sites are femur, tibia, humerus, and rarely it is vertebral. The wall is fibrous. You may find giant cells, you may find postured tissue. There can be secondary ABC also that can be seen in giant cell, that can be seen in chondroblastoma, it can be in CMF, it can be seen in osteoblastoma, and it can also be seen in osteosarcoma. It can be mistaken for malignant tumor due to great rate of growth and destruction of bone. The rate at which ABC destroys the bone is very alarming. So that can be mistaken for a malignant tumor. The clinical features are very classical. The patient may present with a pathological fracture, pain and swelling is often seen. Treatment is you have to do a thorough curettage, you have to do a bone grafting. 50% of them ultimately recur. And when it recurs, you have to do a total excision. Recently, what we do is we give multiple injections at a frequent interval. That injection is of sclerosing agents. Now, what we give is a multiple injection of polydoconol. This is a sclerosing agent which causes, see, aneurysmal bone cyst is due to accumulation of blood, excess of vascularity. So you have to sclerose the vessels which are causing it. This injection is very fruitful, and it has been seen that this works wonders. Here is an example of aneurysmal bone cyst of lower end of fibula. See how the cortex is expanded, and hence it could have been taken for a malignant tumor. It is a purely lytic lesion. It's not aggressive, but it's very expensive. On emptying out, it was hollow. You can see it. Now we come to unicameral bone cyst or simple bone cyst. It is not very uncommon. It is a neoplastic, non-neoplastic osteolytic lesion in metaphyseal area. There can be two types: active cyst, which is close to growth plate, high recurrence rates, and either it can be a latent cyst away from the growth plate, which has less rate of recurrence. Incidence is 3%, only after giant cell tumor. Age, 50% of seen is less than 10 years, and the other 40% is seen 10 to 20 years. Again, males are more informed. Usually seen in upper end of humerus, 55%. It can be seen in upper end of femur, 26%. When you see inside, The periosteum is lifted and underlying bone is eggshell thin. The bone is very weak. It is semi-translucent, easily penetrable. Single cavity contains yellow fluid. So when there is a cyst which has blood, it is ABC. When there is a cyst which has yellow fluid, it is simple or unicameral bone cyst. Features the patient may be asymptomatic, but may present with pathological symptoms of pathological fracture. The patient may have pain, growth disturbance can occur if it is near growth plate. Many of them spontaneously orbitrate. 15% of the cases undergo this process. It is maybe usually the patient has a fall, there's a fracture, and it heals. Very interesting. It is also called as solitary bone cyst, SBC. It is basically unilocular. It has thin fibrous walls. There may be vessels, lymphocytes. It may contain osteoid. You can see in this slide. When there is a pathological fracture, you can find a floating fragment and it is called as fallen fragment sign. The treatment is you can cure it and do bone grafting, high rate of recurrence. You may totally excise it, or when the cyst is small, you can give a small steroid injection in the joint. Multiple injections in the joint usually heals. This is the X-ray of the humerus, the child with simple bone cyst. Cortex is not expanded, it is a latic lesion. There is a narrow zone of transition, and it underwent pathological fracture. You can see in the MRI also. One of the less frequent tumor is NOF. It is non-ossifying fibroma. It presents with a metaphyseal fibrous defect, silent small fibrous lesion, 2 to 3 millimeter diameter, common developmental lesion in children in metaphysis causes thinning of the cortex. Usually disappears within a few years, rarely few enlarged to 4 to 5 centimeters. Incidence is almost 2%, usually seen in less than 14 years, always seen in long growths. On histology, it is made up of fibroblasts with little collagen, small giant cells, and total absence of osteoid tissue. Clinical features shows pain and swelling, pathological fractures can be seen. On X-rays, it presents with a radiolucent thin lesion lying excentrally in the cortex or medulla leaving behind thinned out subperipheral cortex. Treatment can be curettage and bone grafting. Multinucleated giant cells can also be seen. This is non-ossifying fibroma, latic lesion, narrow zone of transition, cortex has not expanded. Now, we are about to read a very interesting bone tumor, which is called as fibrous dysplasia. It is basically an intrinsic defect of endochondral bone maturation, which ends up in formation of immature ossification, and the absorbed bone is replaced by fibrous tissue. The incidence is not much, although it is 0.8%, and the common age involvement is 3 to 15%. Site is diaphysis or metaphysis of femur, tibia, and fibula. Pathology: appearance of the immature bone in a sea of fibrous connective tissue. Immature dysplastic trabecular round, plump, multinucleated giant cells can be seen. Clinical features include pain in the weight-bearing bones, marked deformity, and patient can end up in pathological fractures. When you see the weight-bearing bones abnormally shaped, there is marked deformity, you must always think of fibrous dysplasia because the bones are fibrous, they are very weak, they are elastic. And one such deformity is called as Shepherd, it is PHE, Shepherd hook deformity of the proximal femur, which is very common, and it can vary from 1 to 30 centimeters. One of the variant is Albright syndrome, which includes precocious puberty, fibrous dysplasia, and there can be brown skin patches. Uh, they may have some spindle cells and collagen too. The osseous component is very interesting. It can show a variety of shapes called as Chinese letters. It may be woven type, but there are no osteoblasts. These look like Chinese letters, you know. X-ray shows cyst-like lesion in diaphyses or metaphyses with industrial scalloping, with or without bone expansion. Uniform distribution of this plastic trabeculae gives ground glass appearance, and candle flame appearance is characteristic. Because of the distribution is so uniform, X-rays appear like a ground glass appearance. And sometimes it can also give candle flame appearance because in the lower part is a normal bone, in the upper part there is fibrous dysplasia, so that appears like a candle flame. Treatment is to supplement this plastic bone with bone graft to produce strength to prevent deformity and fracture, then to eradicate disease. Hence, curettage and bone grafting is the basic treatment. It is a classic example of Shepherd crook deformity. So these were the most important of the benign tumors which we have read. If you have any questions, any doubts, you are now free to ask. Or you may WhatsApp me and then we'll see. I'll try to answer. All the best.